what's the data really telling us here, right? And what we found fairly early on, I mean, within the first few weeks of the crisis, is that the data wasn't really telling what the media, right, and what at that time, the so-called experts were telling us. Did it make sense in terms of what we were seeing with our own eyes? So there was that, but also we were told these incredibly high fatality rates. This was the thing that was driving it from the beginning. We were given this impression that if you got this infection, there was a pretty good chance you were going to die. That was the thing. And so that's what we focused on. That was the first thing from a statistical probabilistic perspective that we focused on. When you looked at the data, it wasn't possible to get those peaks like that consistently in each of the age groups. And there was a much simpler explanation. And that simpler explanation was that people who were dying shortly after vaccination were being classified as unvaccinated deaths. Those who rely only on the mainstream, right, whether it be BBC News, Sky News, or the mainstream newspapers, will be completely oblivious to almost everything that we've discussed today.
Welcome to the Radical Health Rebel podcast with your host, Lee Brandon. If you enjoy the podcast, please leave a 5-star rating and a warm review. And now, here is Lee, the Radical Health Rebel, with this week's podcast.
Professor Norman Fenton, welcome to the Radical Health Rebel podcast. How are you?
Yeah, thanks. Yeah, I'm good, thanks. Yeah, thanks for having me on.
It's great to have you here. So the title of today's episode is Misuse and Misinterpretation of COVID Statistics with Professor Norman Fenton. In January 2020, we started seeing people in the streets of China nosediving to their doom. By March 2020, lockdowns around the world were being enforced. Based on computer modelling produced by Professor Neil Ferguson of Imperial College, a man whose track record of previous computer model predictions were extremely inaccurate, to say the least. We were being told by a computer billionaire that the only way back to freedom was by the entire global population receiving a yet-to-be-produced experimental injection with no efficacy or safety data. We were told that there were no current medical approaches available, that lockdowns and masks were the only solution until the untested, soon-to-be mandated injection was ready, and that everyone was at risk, and that we had to assume that everyone had the disease to protect Granny. The test used to detect the disease was designed by Kary Mullis, who shared the Nobel Prize for Chemistry in 1993 for the PCR test. Unfortunately, his untimely death was in 2019, but prior to that, he made it clear that the PCR test could not be used to diagnose viral diseases. These tests were used for diagnosis of COVID-19 and used as a key tool into the safety and efficacy of the injections in late 2020. We were then told that the injections were 90 to 95% effective, and the public were reassured by politicians, the media, and TV doctors that the injection, despite no medium or long-term data, would stop you getting the illness, would prevent you from needing hospital treatment, would stop you passing on to others, and it was perfectly safe. Many doctors also believed this to be true. For much of 2020, I tried to warn that perhaps they shouldn't believe everything they hear and to not blindly follow what they were being told by authority figures. I ended many of my social posts with the hashtag numbers easily manipulated, people easily fooled. I was frequently banned from social media sites for sharing factual information as it went against their community guidelines. And in my book released in May 2020, the Coronavirus Survival Guide, that's available for free, I quoted my musical hero Stevie Wonder when he said, "When you believe in things you don't understand, then you're suffering. Superstition ain't the way." Now, I believe it's vitally important to be informed before making potentially life-changing or life-ending decisions, rather than just believing what you're being told by self-proclaimed experts, especially when those experts suppress, censor, and ridicule opposing views and deny the opportunity to open public debate. So today I have one of the most qualified people in the world to discuss the reality of the data around COVID and the COVID injections, a man who has put his head above the parapet and risked much to share the truth of the data. So Norman, I'm really excited to have you on the show today to discuss this very important topic and for you to drop a few truth bombs in the process. So to kick things off, can you share with the audience a little bit about you, your work, and why you're qualified to talk about the data and the COVID data in particular?
Yeah, okay. Well, thanks for that. That was a great introduction. I mean, you've covered a lot of the stuff that that I've been looking at myself, and in fact, a lot of the work that we've been doing has kind of like been geared towards a rigorous analysis and sort of confirmation of some of those points. But anyway, I'm a mathematician by training, and my current focus is on what we call sort of critical decision making, and in particular quantifying risk and uncertainty. And we use a type of mathematics and statistics called a Bayesian approach, which enables us to properly quantify uncertainty and risk when you don't necessarily have all of the necessary data available, where you've got to kind of like combine bits of data, bits of expert judgment, that type of thing. And we're looking for so we don't just do kind of like straight number crunching, which is a lot of statisticians and sort of classical risk assessors do. We try and look for sort of causal explanations for the data that we're seeing. We look at sort of biases, uncertainty about its accuracy, and also sort of key information that's missing. And those are the sort of issues that you see in lots of the data that was coming out around the sort of the COVID era. So a lot of my work prior to the pandemic, prior to that, was actually involved in risk assessment in sort of medical decision making. In fact, I was leading at the time a very large interdisciplinary project funded by the Engineering and Physical Sciences Research Council on improved decision-making risk for chronic medical conditions. So we were looking at, and so this involved looking at this whole sort of risk of, and by taking account of data and expert judgment for things like rheumatoid arthritis, chronic heart failure, diabetes, that type of thing, and also even things like we also look at things like multiple sclerosis, pelvic floor syndrome. So a lot of these kind of like chronic medical conditions, and I was used to working with clinical experts in those fields. So we would basically get the data, and where there was lots of uncertainty about the data and about how to in order to make that to get that data into sort of accurate risk assessment, you needed to get that clinical input. So it was kind of like inevitable that when the whole sort of COVID thing exploded, we would sort of be drawn into looking at doing the same kinds of things, trying to analyze the data, get together, get some clinical expertise involved, and then really trying to explain, well, what's the data really telling us here, right? And what we found fairly early on, I mean, within the first few weeks of the crisis, is that the data wasn't really telling what the media, right, and what at that time the so-called experts were telling us that it was, it just didn't seem right. It didn't seem right. We were told these, you mentioned about the people, you're seeing all these scenes of people sort of dropping dead in China, and then they were showing things from Italy. Well, we weren't actually seeing that here. So already, even from a non-statistical perspective, forget about the data. Did it make sense in terms of what we were seeing with our own eyes? So there was that, but also we were told these incredibly high fatality rates. This was the thing that was driving it from the beginning. We were given this impression that if you got this infection, there was a pretty good chance you were going to die. That was the thing. And so that's what we focused on. That was the first thing from a statistical probabilistic perspective that we focused on.
Yeah, I mean, I myself was looking at the data, probably not with as good an eye as you do, but it was obvious to me that they were underestimating the number of people that were infected in the first place. And I think, I actually reread my book this morning, and initially they were saying that the fatality rate was 7%. And then I think Jay Bhattacharya was saying it was less than 1% at the time.
Yeah, and also John Idees. Well, we actually we were one of the first. I think we might have been the first to actually have a peer-reviewed paper published on the infection rates and the infection fatality rates, right? And what we did there was what we reported was indeed exactly what you've just said, that the infection rate, the number of people who likely had this virus, was at the time much higher than was being reported in that sort of spring of 2020. Whereas the infection fatality rate, that's the probability that you're going to die if you are infected with it, was far lower. It was much lower. We got that by just looking at the publicly available data from all of the different sources that you could at the time. And we applied our kind of like a Bayesian analysis to that. And and in fact, the data that the results that we came out with were consistent with what people like John Ioannidis, and Jay Bhattacharya. In fact, we were probably predicting, we were actually estimating even lower rates. And of course, even then, it was clear that the risk of death, the risk of death of anybody really above the age of sort of 80 was incredibly low. And that, this whole, that almost, what can you call it? It's kind of like a mania around it. I mean, the interesting thing here is another thing that was, of course, driving. You mentioned about the PCR test. Now, originally, in that early period, the reason why you had this kind of like part of that mass hysteria and the overestimation of the fatality rates was actually at that point, the only people who were getting actually tested, who were getting the sort of the PCR tests, were apart from sort of frontline health workers, but they were just a small, tiny proportion of those. The main people who were getting tested, of course, were people who were already severely ill, hospitalised with the virus. Right now, if the only people you're testing are already severely ill with the virus, then you're going to get this exaggerated fatality rate. But remember also, and this is something that we didn't know at the time, right? And I'm increasingly of the belief now. Again, this is mainly coming from the very experienced clinical people I've worked with, and these are people who maybe have to still remain anonymous, actually, if they're clinicians. Is the evidence that much of that early death wave, the real death wave, and there was a real excess death wave of COVID deaths in March and April of 2020, was due to inadequate, poor medical procedures. They were given the wrong treatment. We know these people shouldn't have been put on ventilators. There were plenty of early, and they shouldn't have been given things like remdesivir. They shouldn't have been, they were given essentially drugs which were not the right treatment for people with that type of condition, and also they weren't given people who in the early stages of the virus, in the early stages of the virus, were not given perfectly well treatments that we know are quite effective. I won't go into the details of that, but I mean, I think probably your listeners, will be aware. But there were and are plenty of early treatments which have subsequently been proved to be very effective, and they were known at the time.
Yeah,
they were known at the time. But as you said,
I mentioned in my book there was a study, albeit it was from China, and it was a relatively small study. But they did a study, people with COVID. This was pre-March, so this was early 2020. And they did a study, and they gave some of the patients hydroxychloroquine, azithromycin, zinc, and there was one other, I can't remember what it was. 100%.
Probably vitamin D or something.
No, heparin, I think it was. 100% of those were symptom-free and PCR negative within 5 to 6 days, 100% of them. About 50% were symptom-free and PCR negative that just had hydroxychloroquine on its own. And there's a lot of studies out there saying, oh, hydroxychloroquine doesn't work, or it's not very good. Well, if you put it on its own, it's probably not that effective. But if you use it with the other treatments that were known to be very effective, then you're going to get much better results.
Yeah, I mean, that what really effectively killed the hydroxychloroquine as a treatment throughout the world was this ridiculous, this fraudulent study that was published in Lancet Surgery study. I mean, do you know about that one?
Yeah.
Yeah, I mean, they were basically giving they were giving wrong dose. They were, some people argue deliberately giving wrong doses. I don't know about that.
They were lethal doses,
certainly they were overdosed on it. It was the wrong dosage, and then you've got I mean, there was all kinds of flawed. There's all kinds of flawed studies, and yet when there've been subsequent studies into things like ivermectin and other treatments, they've tried to claim that those studies don't live up to the high quality of the randomized controlled trials that we expect, and then there's been again the other more recent studies which have attempted to kind of like delegitimize use of things like ivermectin. Those are also proven to be highly politicized and flawed. So we did look in. We actually looked at all of the studies into ivermectin. We did a meta-analysis, and even if you take out the studies which have been claimed to have been kind of like themselves fraudulent or kind of like implausible, even when you take those out, there is very solid evidence that ivermectin, when applied early and in conjunction with some other drugs, is effective. And so this has been a major part of the scandal, really, that refusal to consider these early treatments, alternative treatments.
I mean, I've got an idea as to why they were suppressed. Have you got any idea as to why?
Yeah, I do believe now that they were suppressed because if it had been established that there were there was some adequate treatment, then the injection, the injections would never have got the
emergency
authorization. Yeah. Emergency authorization use. That's the thing. So that was needed. That was a necessary requirement to get that authorization.
And one of the things as well, I think that was potentially misleading was, this is something perhaps you could explain, is the difference between an absolute and a relative risk.
Yeah, so let's take an example. Let's take the example of colorectal cancer, which affects, let's say, obese people and non-obese people slightly differently. So the figures here are not exact, but they're roughly what is kind of like known. So basically, 2 out of every 100 non-obese people will die of colorectal cancer, and about 3 out of every 100 obese people will die of colorectal cancer. So we can ask the question, well, what's the risk of dying from colorectal cancer if you're obese? Well, the relative risk is 50%, because the way we calculate that is we say we have to look at the percentage of obese people who die of colorectal cancer, which is 3%, divided by the percentage of non-obese people who die of colorectal cancer, which is 2%. So it's 3/2, and then it's 1 minus 3/2%, which is your 50%. So you can say there's a 50% relative risk of dying of colorectal cancer if you're obese. But of course, the absolute risk is just the difference. It's just 3% minus 2%. It's just a 1% increase. So you've got a 1% increase of dying from colorectal cancer if you're obese. Now, if you think about it, that's the one that's really important. It's that 1%. It's the absolute risk. It's the one which is actually which is actually meaningful. The relative risk is generally, of course, massively exaggerates risk in most circumstances. It has its. There are times where we do want to use the relative risk, but in most of these cases, and particularly the cases where it's used in reference to to COVID and stuff like that, and the vaccines, etc., it's much more reasonable and intuitive and meaningful to use the relative risk. To use the absolute risk rather than the relative risk.
Yeah, but yet we were being given the relative risk.
Yeah,
absolute risk.
Almost always the relative risk, which always exaggerates the risk in people's minds.
Yeah, yeah. So the next thing, I guess, that's quite important on the subject of the data around COVID. I think within the first 12 months, it was something like 170,000 reported deaths in the UK, somewhere around there. But there's a difference, of course, between dying with COVID and dying because of COVID.
Yeah.
Can you give us a little explanation of that?
Yeah, so I can give you the numbers and also an explanation for it. So first of all, we know that the classification of a person dying, those who were classified as COVID deaths, were anybody who died within 28 days of a positive PCR test or who were clinically diagnosed with COVID. But the key thing is almost all of them, it's within 28 days of a PCR test. And of course, that means if somebody, happens to be died in a road accident, within some time after they tested positive for COVID, then they'll be classified as a COVID death. And dying doesn't matter what other morbidity led to their death. If they happen to have a positive PCR test, they'll be classified as a COVID death. So that's now, at the time, this wasn't well known. I think people now, that's something that people are now, at least are kind of like well aware of. But how does that translate into this actual data? Well, there was this an interesting Freedom of Information request made at the end of the most relevant one, which was the end of 2022, which asked for the number of all COVID classified deaths and how many of those were in people who had no other serious comorbidities. And at the time, you mentioned the figure of 170. I think the figure I saw was maybe for England, which was, I think, 135,000, and less than it was less than 4.5% of those. Less than 4.5% of those deaths were people who did not have some other serious comorbidity, right? So it's a very low percent. So in general, it's less than 5%. And of course, it's particularly interesting when you look at the data for young people. So for people under the age of 20, we now know from another Freedom of Information request that I believe, again, up until certainly it might be even a later period, but certainly the first, sort of the first 2 years of the pandemic, it's something like, I believe it's only 3 people under the age of 20 without any other serious comorbidity have died. So when you hear this, when you talk about the risk of death from COVID to young people, well, there's something confusing about that as well, because people don't realise that you've got to make the difference between what's the probability of dying if you've got the disease, as opposed to what's the probability of you dying from it. So you've got, there's a difference there. But even so, whichever way you look at it, when you get these numbers of 0.0000, these are really incredibly tiny probabilities. There is essentially, when we say there's essentially no risk of young healthy people dying of this disease, it's certainly it's not non-existent, but it's similar to, I think, probably less than flu for young people. I think more young people will die of flu than COVID if they're healthy.
So what I think, a lot of people still believe is that well over 100,000 people have died from COVID, when perhaps that's nowhere near the truth.
Yeah, they've died with COVID rather than from COVID.
I've used the analogy, you could die wearing underwear, but underwear didn't cause you to die, right?
Well, exactly. Yeah.
And, a lot of people early on who didn't like the fact that I was suggesting they think for themselves were saying to me, well, they might have had other morbidities, but if they didn't get COVID, they wouldn't have died. And I would say, well, how do you know that?
Yeah, we don't know that. These are counterfactual questions. We don't know, but the data, what we know, the kind of data analysis that we've applied suggests that wouldn't be that wouldn't be the case. I mean, it's interesting there. I noticed I was making a note in your introduction. You were talking about you used the analogy of I think it's Stevie Wonder song. There's another analogy of a famous song here with this whole point about COVID, that once once you've been positive PCR tested with COVID, then for quite a long time afterwards, if you for whatever reason, if you happen to get hospitalised, you're still going to be called a COVID. You're sort of a COVID case for sort of quite a long time. It reminds me of sort of the Hotel California here. You can check out anytime you want, but you can never leave.
Yeah, that's definitely a good one. I mean, another analogy I used to try and suggest to people and say, look, if you look at the people that are getting ill and dying, they're either over the age of life expectancy anyway, or they've got other and often severe morbidities. And the analogy I would use and say, how many people die of the wind blowing? Well, people generally don't die of the wind blowing. And I said, what if you were walking along the edge of a cliff?
Yeah.
Would you say,
an analogy, yeah,
if the wind blew you off, would you say the wind killed you? Well, no, hitting the ground at a high speed would kill you. It's just the wind that blew you off because you were right on the edge anyway.
Yeah.
But a lot of people got offended by me saying that. But
well, I think again, even the Office of National Statistics kind of like concede that a very large proportion of those deaths in the in that early period of early spring of 2020 would likely, a lot of those people would likely have died within a kind of a 6-month period anyway.
Mm-hmm. Yeah, because I think the average age was 82 point something early on.
Yes, it was. Yeah, and and when you combine that with the fact that they were given inappropriate treatment, which likely speeded the deaths anyway, as well as the virus itself, you've got that combination of effects which led to that very high number of deaths. Now, incidentally, one of the other things that we've done in our analysis is that we believe that whereas there was a genuine, let's say, excess peak in death due to the virus in that that early period, the so-called massive second and third waves, which they talk about as being far greater, far greater than the first wave, that we don't believe that those were truly major waves. I mean, those were mainly due to the massive increase in testing of asymptomatics. Right, you get these massive you've got these massive increase in case numbers, right? So, people who, many people who didn't even have the virus but were classified as having the virus. That's the thing that was driving these. You did get this massive increase in number of COVID cases in that so-called second wave from sort of starting sort of October, November 2020, and you look at the case numbers. The case numbers went up to sort of much higher than in that first wave. That's because we were testing far many more people, and also in contrast to that first wave, where as I said, we were only testing people who were sort of hospitalised, seriously ill with the virus. We were testing everybody. That was when everybody was going back to all the kids going back to school, people going back to work, when the lockdowns first. When the first lockdown was being eased, everybody was having to go out and get tested sort of every day or every other day and all that kind of thing. So this incredible increase in testing, mainly of asymptomatic people, and we know from part of the serious work that we've done how it's not a question of how inaccurate those tests are. It's the fact that a very large proportion of those of asymptomatics who test positive will not necessarily have the virus. So that's where you get these. That's the false positive rate of interest. It's not how accurate the test is, but what proportion of those who are asymptomatic, who test positive, have the virus, and that's generally a lower percentage of those who are testing positive.
Yeah,
and that was what was driving those numbers. And as I say, if you look at other indicators at the time, what I believe are more accurate indicators of the true scale of the disease, you can look at the NHS dashboard. The dashboard there's a COVID dashboard for 999 calls, right? Ambulance calls and 999. So COVID's triage calls, right? And there you see you do see a real peak in the spring of 2020. But when you look at that so-called, what was supposedly the massive peak later, winter of 2020-21, actually it's a ripple. It's like much like you see in any other sort of flu type virus. It goes up a bit, but nothing like it was initially. Whereas you're getting the opposite view of a massive wave when you just look at the COVID not the NHS dashboard, but when you look at the COVID dashboard that was used by all the TV stations and the media to show this massive wave.
And in terms of the known risk factors, is that something you've looked into in terms of the data?
Yeah, so interesting enough, it was looking at the risk factors early on that wasn't considered controversial, so we had some stuff published about this. We looked at things like the differences in ethnicity, which again I think were a bit exaggerated in terms of the. There was a lot of stuff on, for example, BAME people being especially at risk, and it turns out actually it's much. It's not the ethnicity, but it's the sort of the socioeconomic factors and things like the size of the household, number of people in households, and that, which are the root causes of that type of thing. We looked at, interesting enough, the smoking risk factor. That was of interest because it was being claimed that smoking was actually an inhibitor. That actually, smokers were less likely to get COVID, and it turns out that analysis that was kind of like there's a sort of a classical probabilistic issue there, which was maybe creating something of an illusion on that. I think that there may be a little bit in it, but again, that was exaggerated, any effect there. So that was the type of stuff. Certainly things like obesity, vitamin D deficiency did seem to be important. But yeah, so there are these various factors, but of course, by far and away the most important one is age. I mean, age, compared to the rest, it blows them all out of the water.
Yeah. I mean, one of the things I saw early on was that smoking reduced your risk of getting COVID, but if you got COVID, it increased your risk of dying compared to a non-smoker.
Yeah, but this is, again, it's all to do with these complex causal relationships that you've got going on, which lead to sort of counterintuitive results. The reason why you'd see maybe the apparently be less likely that smokers get are infected early on. This is again all connected with what type of people were being tested early on for it. Okay, and other than people who are already seriously ill in hospital, right? The only others who were being tested early on were frontline hospital staff. They tend to not be smokers. Okay, and so there was all kinds of interesting, confounding, and complex causal interactions around that.
So again, that's another example of numbers easily manipulated and me being really fooled.
Yeah, I mean these kind of like statistical illusions. I mean, early on you've got this. Very early on, to be fair, there was a statistical illusion, a well-known statistical illusion, which was claiming that right from the very beginning that the vaccines were sort of very unsafe. But it was actually now got a lot more to say about that, what we know now about the true sort of safety and efficacy. But very early on, there was misleading information put out that, oh, look, the vaccines are really unsafe because they're killing because the vaccinated are dying at much higher numbers than the unvaccinated. Well, at that point, people were simply looking at the overall numbers, which, without taking account of the fact that most of the people who were at that time most likely to have been vaccinated were the very old. So of course they've got a much higher and some far more of the old people getting vaccinated. So virtually all of the deaths were in that older age group, and in the younger age group, very few were getting vaccinated. Relatively few deaths. So, but when you aggregate it together, right, you get this misleading result that it looks like it's the vaccinated dying at a much higher rate. Now, of course, since then, and so that's an example of where the statistics were being wrongly used to claim something that's kind of like an argument against the safety and efficacy of vaccine. But since then, there's been lots of arguments the other way. Lots of statistical errors have been made to paint the vaccines as safer and more effective than they truly are. And of course, that's something that we've examined at depth, in the last year, actually.
Just on your previous point about, more older people were injected, but then more older people die anyway.
Exactly. Yeah.
And that's why it's always important that when you're looking at statistics, you need to do it in age groups.
Yep.
You can't just look at the whole population as a whole and say, well, it's this or it's that, because as we know, the chance of a 10-year-old getting and dying from COVID is very different from a 90-year-old.
Yeah.
That's an extreme example, but it's a valid example.
Yeah, and one of the problems that when we first started looking at the vaccine mortality surveillance data that was being put out by the Office for National Statistics, because we decided that the only fair way to determine whether the vaccines were safe and effective was to look at this all-cause mortality and to look at it in the different age groups, these different age groups. And one of the problems we had first of all was they weren't properly. They only had these incredibly crude age categorizations. I think initially they were doing things like under 50s and sort of then over 50s in 10-year age brackets, and that wasn't sufficiently refined to be able to make any definitive conclusions. We needed these. Yeah, you need to have these fairly refined age categories. Certainly, 5-year age groups is certainly what you need. And if you haven't got that, then they use this so-called age standardized mortality metric, which I'm never really comfortable with that. I mean, I don't want to go into there's some complex statistical issues around that, which I sort of don't really want to go into here, but that's where they try and combine it, where they're trying to, instead of saying, right, well, instead of going for each of the different age groups and saying, here's what the risk is, here's what the benefit is, which is what you should be doing, they'll give an overall, they'll say, right, we've got this age standardized metric, which enables us to give an overall judgment of the risk and benefit. Well, that can be highly misleading as well. And that's problematic. So we very much prefer to go for these very specific age categorized distinctions.
And obviously we've got, I guess, almost 2 years worth of data now from people that have been jabbed so far. What's that looking like in terms of mortality of the jabbed versus the unjabbed?
Well, that's a good question, because it is all-cause mortality is the metric we should be using to determine the safety and effectiveness of the jab. Because think about it this way, if COVID is as deadly and serious as claimed, and if the jab is as safe and effective as claimed, then what we should be seeing is more people over a given period in each age group dying of any cause. Forget about whether it's COVID or non-COVID, because we've got all those problems about the classification. There should be more people dying from any cause if they're unvaccinated than if they're vaccinated, for the following reason. First of all, if it's deadly and the jab is safe, then those who are unjabbed are going to be supposedly getting COVID and dying, compared with those who are jabbed. So you should be seeing this big difference in mortality due to the COVID deaths, right? But on the other hand, if the jab is safe, right, it doesn't have any serious, isn't killing people through adverse events, then you shouldn't see much, you shouldn't be seeing any additional excess mortality in the jab compared with the unjabbed. So when you put those together, what you should be seeing is fewer people dying in the jab group than fewer people dying in the jab group than the unjabbed group in each age group over, let's say, some reasonable period of time that you want to look at this. So we're looking at like 6-month periods. Well, we're not seeing that. What we've done is we've of course looked at the Office of National Statistics data on this, and we've kind of like had problems with that, because superficially, when this data was first being released, it did look like it apparently was showing that the unjabbed were dying at a much higher rate than the jabbed, right? And it was showing in each age group as well. And this was when we looked at this, we actually found that there was flaws in the data, right? What you were seeing was unnatural data. What we were finding was that when you looked at the non-COVID deaths, you were finding these massive these spikes in mortality of those who were unjabbed at the very time that the vaccine rollout was happening for that age group. Now, why would the people who are not getting jabbed at the time when all the others are getting jabbed in that age group suddenly start dying of non-COVID causes? Well, of course, there is an explanation for this. There's a number of explanations for this. The one that the ONS tried to say was, well, actually, it's something to do with they call it the sort of the healthy vaccinia effect, that it's only the healthy people who are getting vaccinated. So the unhealthy ones, the ones who are sort of about to die or close to death, we're not getting vaccinated, and so they're sort of dying at that time when the rest are getting vaccinated. Well, we showed both. We showed empirically and theoretically this wasn't true, because we know that empirically that actually even people close to death, for example, in care homes, these people were the highest risk people, most critically ill people, were prioritised for the jab in 2021. We know that, and even people who were in care homes and were sort of even those close to death were given it, because it was felt that they don't to avoid because COVID could be a horrible death. If you've got it, to avoid that sort of horrible death, it's better to be jabbed. So that was nonsensical. Theoretically, we showed when you looked at the data, it wasn't possible to get those peaks like that consistently in each of the age groups. And there was a much simpler explanation, and that simpler explanation was that people who were dying shortly after vaccination were being classified as unvaccinated deaths, and that was it. That's the explanation. Now, this shouldn't be a surprise for various reasons. For a start, it comes back to this definition of who is a COVID case, what is a vaccinated person, right? So, officially, for all of the studies on effectiveness of the vaccine, somebody who gets COVID within 14 days of being vaccinated is officially classified as unvaccinated, because they say, well, the vaccine hasn't had a chance to take effect yet. Now, there is some, you can sort of see some justification for that, but then you need to make allowances for the way you do the analysis of effectiveness, and they don't properly do that to take account of this. But the fact that all these people, in fact, just imagine that you had a vaccine which was just a placebo, right? Which had no no effect whatsoever on those who got it or didn't. If you do that type of, and if there was some consistent rate of people getting some virus, then statistically, using that approach, that placebo will always be seen to be very highly effective. It just, because you're just not counting all the people, you're taking out all the people who've been vaccinated who get the jab and moving them into the unvaccinated category for those first 2 weeks after vaccination. Now, when it comes to deaths and vaccination, officially, of course, if you die shortly after a vaccination, it should be classified that you have had the jab, right? But for exactly the same reasons, that they're trying to, for the same reasons why they're classifying a person as unvaccinated if they get COVID within that period, if they get the virus in that period. Similarly, they're classifying them as unvaccinated if they die. Now, what the ONS say, and incidentally, this is routine we know that that is routine in many parts of the world. Now, to be fair, the Office of National Statistics, they say no. They say no. We do it from date of vaccination and date of death. So it doesn't matter if they died, even just 12 hours after vaccination, that will be counted as that death will be counted as a vaccinated death. Well, it's all very well fine for them to say it, but they get the data from various different bits of the NHS and various different bits of the recording system of the NHS, and we know that the mistakes are happening elsewhere. They don't get the correct data. If someone dies shortly after vaccination, their death is going to certainly be recorded, but is their vaccination date going to be recorded accurately? Almost certainly not. So that's where these kinds of problems come in, and we've looked over the whole period when they've been releasing these reports, and it's clear that in 2021 especially, this was a big problem of misclassification, those deaths. If you adjust for that, if you make adjustments for that, then you find that there is no real difference in all-cause mortality. In fact, if we looked at the recent data, we don't trust any of it. It's so flawed. There are so many flaws in this data, not least because overall, where the overall mortality rates are just wrong compared with historical data. When you just look at non-COVID deaths, right, and compare them with the previous periods of non-COVID deaths, it's not right. They're lower in all age categories, which doesn't make sense, which suggests that they're missing. Well, we know they're missing a whole load of deaths, right? We know that they were missing a whole load of vaccinated deaths, right, in their data. And so once you take account for this, not only is there not this drop in all-cause mortality in the jab, but if anything, in certain age groups there might be an increase. We found that in some of the younger age groups, the all-cause mortality actually may be higher in the jab than the unjab. So, interestingly enough, it's also in the 90+ age group. But anyway, the thing is, the data isn't good enough to make any definitive conclusions, right? We should definitely have expected to see these drops in all-cause mortality in the vaccinated compared to the unvaccinated, but we're definitely not. We're not seeing them. I'm not claiming that the jab is killing lots of people. We haven't got the evidence for that. What we have got is the evidence that they're not doing much in terms. They're not really doing anything in terms of stopping hospitalizations or deaths, and that we know for certain they're doing less than good. They're doing terrible in terms of the COVID infections, because you just have to look around you to know that anybody who says that there's data which claims that the vaccines are stopping, are leading to decreased infection rates, we know that's not true. And it's almost certainly, only. I mean, do you know of any person who was unvaccinated who had COVID naturally and then has been continually getting COVID again? No, but we know that's happening with the jab people. They're getting it over and over again, but it's not happening with the unvaccinated. So the jabs appear to be, creating increased COVID cases. So that's another issue.
So the data is suggesting that the efficacy isn't there.
Yep.
But the data isn't suggesting that they're safe, but it's not also suggesting that they're unsafe. It's a bit muddy, is what I'm.
It's a bit muddy. I mean, the problem is where there's a lot of stuff. Of course, a lot of analysis has been done in sort of excess deaths, and there's a claim. You know, a lot of my colleagues indeed are working on looking at excess deaths as being a way of determining whether there is, you know, potential. What are, you know, if there are significant excess deaths, what the causes? Is it possible that the vaccinations, or it's possible long COVID and stuff like that? So that might be a way of seeing it. The fact that we are seeing excess deaths overall is worrying, of course, because why? You know, if these excess deaths are happening after this mass vaccination period, then, you know, why is it? How much of it is down to the lockdowns? How much is it, you know, to do with lack of access, you know, to so at least less access to the NHS facilities and all that sort of stuff. You know, there's all of that stuff in there, right? But you can look at there are other indicators. There are sort of other indicators when you sort of just look at compare the sort of different countries, the rates of, you know, again all excess deaths or all cause mortality in between the different areas or different countries, different regions, and that. And again, there what you see is, again, there's no evidence of a sort of a mass kill going on, but there is definitely no evidence of any reduction, you know, in deaths, which you should have expected if COVID was what it was supposed to be, and if the vaccines were what they were supposed to be. So the whole thing points to this being, you know, all something of a, you know, I wouldn't say a fuss over nothing, but certainly the world has been changed in these, you know, for the worse in many ways, for something that was maybe not necessary. And yeah.
So my understanding is that all-cause mortality did go up, you know, in 2020, as you'd expect, because it was a pandemic.
Yeah.
But my understanding is that all-cause mortality rate this year is even higher. But you'd expect if there's been a pandemic and lots of death, you'd naturally see a drop in all-cause mortality. Would that be a fair comment?
Yep, that's a fair comment. Incidentally, even the 2020 mortality rate was not that high anyway. I mean, I think that, you know, if you look back over the period, sort of the last 20 years, it certainly wasn't the highest.
And I remember looking at the stats in 2020. If you look back 30 years, it had the 15th highest level of mortality.
Yeah.
So
exactly. So it wasn't massive, but 2022 is looking to be, you know, far worse. And as you say, if a lot of the very vulnerable people were kind of like taken out in 2020 and 2021, then you would expect, given that we now have this, you know, this great vaccination, mass vaccination program to avoid this, you know, to stop people dying from this virus, you would have expected the numbers to have come down, not gone up.
Yeah. And the other thing I'm seeing as well is that it's the younger age groups that are tending to make up quite a lot of the excess mortality. Is that correct?
That is correct, yes. Now, of course, there are, again, the numbers, because in those age groups, the overall numbers of deaths are relatively small. Okay, so these are not like, you know, in the UK, they're not massive numbers, but so you'll tend to find that you don't get massively statistically significant differences, at least not yet. So again, we're still looking at. I'm a bit more skeptical about the excess, about looking at excess, the way excess deaths are being looked at than others, let's say, who are on the skeptic side of this argument, because I still think we need to see some more data there, especially in the young.
I mean, the other thing, again, correct me if I'm wrong, but a lot of the excess all-cause mortality, a lot of it's heart-related as well.
Yes.
And then we do know, I think it's fair to say we do know that these injections do cause myocarditis and pericarditis. It's almost like, is it such a massive leap to suggest that might be linked?
Well, I think the evidence is there. I mean, I try to avoid the sort of the clinical issues about explaining the links between these. Again, my esteemed clinical colleagues, who mostly have to be anonymous because otherwise they lose their jobs, have certainly convinced me about that link, and the data suggests there is that link especially in young males, of course. And again, we're seeing plenty of anecdotal evidence of that in sort of young athletes, especially, because that's of course a special problem when the heart's under stress, as in intense sports activities, and these are not things we've been seeing before. That we didn't see these on anything like this on this scale before.
Yeah, I mean, I'm an avid sports fan, and I can remember maybe 3 heart attacks or heart problems during a match. I'm talking over a 50. Well, I've probably been watching football maybe 45 years, and I can remember.
Yeah, same. Yeah.
And then there was more than 3 in a month, and that wasn't
exactly. Yeah,
it was over a period of time. So there's definitely, my opinion.
Yeah, and those were all genuine. And the thing is, they never, they always coy to say, you mustn't sort of say anything about their vaccination status. I mean, it's interesting, isn't it? We were told we had to give our vaccination status to go, to enter a sort of a restaurant and stuff like that. But you're not allowed to ask for vaccination status of somebody who's just sort of dropped dead on a football pitch or something. It's a bit weird, but it's one of those weird idiosyncrasies which has become sort of commonplace in the sort of the COVID era. But yeah, most of those, certainly professional sportsmen, would have had to have had the jab in order to go abroad and play in the tournaments they were playing in, etc.
Yeah. I mean, there were some Manchester City players that didn't go on the American tour this year. It's quite obvious why they didn't go.
Yeah, that's interesting. Right. Yeah, I didn't know that actually.
So that was interesting. So something you touched on earlier, I want to just ask you, kind of just to cover it in a bit more detail. So I've heard a lot on via the media and politicians, it's kind of a throwaway comment. Well, this vaccine has saved millions of lives.
Yep.
Do you know where they're getting their data from?
Yeah. So the interesting thing about that is that, again, fun enough, the paper that was published on that, which claims to have saved worldwide over 20 million lives, that also came from people at Imperial College, not Ferguson himself, but again, people similar to, again, based on these very, very similar models, right? And they were assuming exactly as they were assuming these massive exponential increases in COVID cases without sort of lockdowns. They were doing exactly the same kind of like assumptions about what these increases were going to be without the vaccine program, without taking any account of what the reality was in terms of the trends anyway. And again, it's exactly making exactly the same mistakes that they made in their projections. I mean, you've got to remember, they were projecting. People say, oh, well, their projections weren't that bad. They were initially projecting 500,000. They were projecting 500,000 deaths in the UK without lockdown, I think in the first 6 months or something like that. Right? If there wasn't lockdown. So they were similar types of completely ludicrous projections without taking account of what was really happening. In that case, they weren't even taking account of things like what proportion of the population would get infected and stuff like that, and how many people would die. They were, of course, massively overestimating how many people would die if they didn't get infected. And they're making the same mistakes, exactly the same, mistakes on their sort of estimating their parameters in those models. They're completely meaningless. They're just garbage. And then it's ridiculous. It gives mathematical modelling a very, very bad name.
So it sounds to me like they've taken the original model and said, right, X number are likely to die. This is how many have died.
Exactly, and take the difference. You've got it exactly there. That's exactly what they've done.
Yeah. So do you have any data on the safety of the jabs with pregnancy and fertility, stillbirths, that kind of thing? Thanks for watching the Radical Health Rebel YouTube channel. If you enjoyed this video, please be sure to share with your friends and family, or share via your social media. Hit the like button, subscribe to the channel, and hit the bell icon to receive notifications of new video clips from the podcast. And if you want to watch the full episode, completely ad-free, plus premium content, and join the Radical Health Rebel Patreon community, head on over to the Radical Health Rebel Patreon channel at www.patreon.com/Radical Health Rebel. Thanks again for watching.